Dr. Kalpana Datta is a professor of pediatric medicine, Medical College, Kolkata, and program director, pCoE MCH, Kolkata. She is a national trainer of IMSAM, state trainer for URSH, and specialist trainer in pediatric HIV. Dr. Kalpana is a guide for thesis, project and research, and adjudicator for postgraduate thesis. Recognized examiner for UG and PG. She has several publications in national and international journals. We welcome you, ma'am, for today's session and request you to start the session. Ma'am, can you please unmute yourself?
Okay, am I audible?
Yes, ma'am.
Just do it. The slides are visible?
Yes, ma'am.
Okay, thank you, Dr. Shweta, for your kind words. Good afternoon, everyone. Today, I'll be talking on ART treatment failure in children. And this is a very complicated issue in children because sometimes treatment failure is difficult to diagnose. We don't have much more drugs in our hand, and then the dose schedule, availability of the drug, the preparation, formulations. Lots of issues are there in treatment failure, dealing with the patient with the treatment failure in children. So I'll be talking on definition of treatment. What do you mean by treatment failure? Suspected treatment failure among the children. When you suspect they are going towards a failure for the first line of treatment, identify the treatment failure as per NACO ART guidelines, because technical guideline to 20 is to come. Formulation of second line ART regimens. What will be the drugs and how to choose the drug, and what will be the combination of drug. Monitoring and follow-up after the second line ART initiation is very important. Each and every point is very important in pediatric aspect. So what do you mean by the ART failure, treatment failure? So what happens? It is the inability of an antiretroviral drug to control the HIV infection. This is a simple layman language. HIV drugs are not able to control the HIV virus. That is a failure. That is a theoretical definition. Factors associated with ART failure are maybe drug resistance, poor adherence, drug toxicity, drug-drug interaction, poor drug absorption. So many issues are there. And we know it is a sequence of events. First, it will be a virological failure. Then when the time will pass and that will, we are not interfering at the virological failure, they will go in a immunological failure. Even after that, we are not going to interfere, then they will come as a clinical failure. What do you mean by clinical failure? Means we, at that point of time, we will be able to diagnose the baby, the children are failing from the first line ART. And that is a clinical failure. So treatment failure time detection, as I said, if you see treatment failure, it starts treatment failure. If here, can you see my cursor over here? Is it visible? Cursor is visible? Hello, cursor is visible. Okay, so if it starts, suppose the treatment failure starts here, then you see after few months, a few weeks and months, and what will happen, the viral load will be high. That means maybe the drugs are not acting on the virus. Maybe cause, maybe anything, I'm not discussing at the moment the causes. So there, if you pick up the patient in this particular point, you can have a high virological load and virological detection, and then that we call the virological failure. You see the graph, and viral load will go up and up and up till there will be immune destruction. Means so viral load is so high and is going to destruct and the CD4 cells, and gradually the CD4 cells are not replaced. Means the production and destruction is imbalanced, more destruction than the production CD4 form cells. So there will be immunological deterioration, and that point of time, if you pick the child, will get the immunological failure. So viral failure after a long time, then there will be immunological failure. And even after that, if you don't interfere, you see the CD4 gradually going down and down, and the viral load is increasing because they are exponentially multiplying inside the CD4 cells, and coming out, while coming out from the CD4 cells, they are destructing the CD4. So what happens, the CD4 is going gradually down and the viral load going up. And in this turmoil, what will happen? All the diseases, all the opportunistic infections which are waiting to infect the children, they're searching for the better opportunity. That's why we say the opportunistic infections which are there but not able to infect because of the increased immunity. So as soon as there's decreased immunity, they will start affecting the children, and there will be sign and symptom. So if you don't pick up the child in this particular point, that's the immunological detection, maybe will have a clinical failure. So after long time, if you are not going to interfere over here, clinically baby will be detected as a failure. There are lots of criteria are there. There may be failure to thrive, persistent candidiasis, both mouth and esophagus, or disseminated fungal infection. There may be pneumocystic urinary infections. There may be LIP. There may be though tuberculosis tuberculosis infection may not point towards the failure. Even the healthy the patient is responding with ART can have a tuberculosis. So tuberculosis can have even the CD4 count is quite high, but other opportunistic infection will be more, and gradually baby will deteriorate. So at that moment of time, it is called clinical failure. So inability to achieve the maintain what according to DHS criteria, they say that if HIV viral load is less than 200 copies per ml, then they call it a viral failure. For WHO, NACO, and government India, the government of NACO, the viral load is more than 1,000 copies per ml based on 2 consecutive viral load measurements in a 3 months interval with a good adherence, then only will say it is a virological failure. Even the NACO says same thing. If the virological failure is defined as the plasma viral load of more than 1,000 or equal or more than 1,000 copies per ml at or 6 months after the initiation of ERT. It's very important. You have to take the history where the baby has taken the ERT for 6 months. With treatment adherence more than equal to 95% adherence must be done for each consecutive of the last 3 months of treatment. It's not that in the first month 95, second month 90, third month 96. It should be consecutively every 3 months, every month will be more than 95, equal or more than 95% adherence. Then only will say it is a virological failure. So it is very important, 2 consecutive. First, we can't stamp virological failure in one study test. It should be 2 consecutive tests. There are some criteria. After 6 months of ERT initiation, so you must have received the ERT for 6 months. After giving 3 sessions step-up adherence counseling, as I said, every month there should be more than 95% of the counseling, and for the last 3 months, then only will say if it all after that is viral load is more than 1,000 copies per ml, will say it is a virological failure. Then what is the immunology definition of immunological failure? Children between 12 to us, because we know we are dealing with the children from 0 to 18 to 18 years. At WHO says up to 18 years, but till NACO still we take the children up to 50, 50 less than 15 years. Above 15 years, the guidelines and say about the we consider as an adult. But in children, again, if it's less than 15 years, that means you have a newborn, you have infants, you have the toddlers, schoolgoers, then the adolescent. So different age groups. So what happens when the children below don't consider below 12 months, above 12 months to 35 months, CD4% falls below the 15%, because we see this percentage of CD4, we don't see the absolute count. If you look for the absolute count, it will be quite high, because the total lymphocyte count and neutrophil leukocyte count is quite high. So proportionally CD4 will be high. That will give false impression that baby is having good CD4. So always look for the percentage. And if it is less than 15% or persistent CD4 level below 200 cells per cubic milliliter for any time. If it's between the 36 to 59 months, then CD4% falls below 10%. That means severe immunodeficiency. Persistent CD4 less than below 200. Children age 5 years and above. If there is like in other criteria, and as you take the adult also, a fall of CD4 count from the base level. or 50% fall from the peak on the treatment level. Suppose after treatment it goes up to 1800, and now it becomes 900. So though 900 looks very comfortably good, but as there's a fall is less 50%, you will think there's immunological failure. Then again, persistent CD4 when you're above 5 years is less than 100 after 12 months of therapy. So concomitant or recent infection may cause transient fall in the CD4 cell, because CD4 cell is not only for the HIV virus. It is the cell which helps us to build up the immunity in our body. So we have many other diseases which can infect the CD4 cell, and there will be decrease in the CD4 cell. So when you're measuring the CD4, it's very important to rule out if there is any other concomitant infection. Even in the other viral infection can have a sudden drop in the CD4 count. Some severe infection can have a sudden drop in the CD4 count. So always look for the recent infection, or is a concomitant infection is there or not when we are dealing with the child and doing the CD4. So after treating that infection, you'll go for the CD4 and CD level. That will give exact information toward the HIV immunological status. So CD4 count below 250 cells per cubic millimeter following clinical failure, or persistent CD4 below 100 cells per cubic millimeter, this by according to WHO. And as I said, the necrosis at the fall of CD4 was from the baseline or pre-therapy line, or 50% fall from the peak value, or persistent CD4 levels below 100 cells per cubic millimeter. And what is clinical failure? When we'll say the baby is in a clinical failure? New or recurrent clinical events. It's not like an upper respiratory. Every 2 months, baby will have an upper respiratory, very common upper respiratory tract infection, diarrhea. So always look for the severe infection, not the diarrhea, because if they'll take some unhygienic food or contaminated food or water, there will be diarrhea. That does not mean the baby is having a clinical failure. So always look for the severe diarrhea, persistent diarrhea, pneumonia, suppurative lung diseases like lung abscess, empyema-thoracis, bronchitis. Then stage 4 condition. What we say the stage 4 condition? Severe, suppurative and recurrent things are usually in stage 4, and after at least 6 months of ART. When baby has taken the ART for 6 months, then if the baby is having some signs and symptoms which will point towards the clinical failure. Or even there's no infection, but there's even after taking, baby is okay, and even after taking the ART, there's a progressive neurological deterioration, developmental milestones are delayed, baby is not acquiring the normal developmental milestones, then also we can think of clinical failure. Then growth failure, again, is very dicey term, because very often there is a change in environment, change in the social issues, psychological issues, like some one of the parent is died or separated, gone out of the town for service and all. There's a parental disharmony, any type of psychological environment in the family, baby might have a loss of appetite and can have a growth failure. So I'll first rule out that. Or there may be some acute infection like a pneumonia and diarrhea, and there is sudden loss of taste, loss of nutrients, and also there may be a growth failure. That does not mean there's a clinical failure. So after proper nutrition, there is a growth failure. After having a nutritional therapy and proper care, then also the baby is not gaining weight, you must suspect whether baby we are dealing with a clinical failure child or not. So definition is valid only when the child has been on ART. So it is a repeatedly I'm hammering 6 months after treatment, and at least three months of more than 95% adherence. So what happened? Why there is a failure? It may be due to commonest is because of the poor adherence, and second is maybe because of the poor adherence around, there may be development of a drug resistance. What happens? We know if you see the life cycle of HIV virus, with the HIV virus enters the CD4 with the receptor sites, and then we know the HIV virus RNA virus, human chromosome is a DNA chromosome. So what will happen when the virus will enter inside the CD4 cell? Now that RNA, we have an enzyme called reverse transcriptase, and this enzyme is very much error prone. So what can happen? The RNA that reverse transcriptase, the name itself implies reverse, so it will form the contemporarily band towards the RNA to form the DNA. So RNA to they'll form a DNA, and that will be error prone. There is some error in some mutation in the DNA. That DNA, when it formed, it will go inside the nucleus, and with the help of integrase enzyme, it will incorporate with a human chromosome, and then again it comes out, and there's a there'll be a protein molecules will be encircled with the virions, and they'll form the provirus. And after forming this provirus, this virus which is formed from this virus, there is a error prone, because there's already some defect in the repairing while from forming the RNA to DNA, and it will come out from the cell. It will destroy these CD4 cells and come out. So these mistakes become integrated. When the life cycle is completed, mutant forms of the virus will emerge. So what will happen if there's a mutant form of virus is emerge, that will be not going to suppress by the drug which they are taking. So that is the one of the important issue, and that is more precipitated and exaggerated by the presence of poor adherence. So mutant forms of HIV arises frequently during the viral replication. As I said, I have shown, during replication RNA to DNA, and again DNA incorporates the human chromosome. The faster the virus replicates, the more mutation. In hurry, they make some they make some more deformed, or that is called mutant nucleotides and the DNA gene. So there will, if the faster the replication, there will be more and more resistance virus will come out. Most mutation make the virus weaker than wild type. So after that, it will die out. So there will be mutant gene, and then it will go up. But if a patient is on ARV treatment, some mutant forms may prove to be stronger, because in the mutant gene, they are not the drugs which are not going to suppress that mutant gene, and then they will be more stronger than the previous virus, than the wild type. Such mutants are resistant virus, and through the process of natural selection, resistance virus, if you go the natural selection criteria, you'll see that will dominate, eventually makes the ARV inactive. What will happen? There's a mutant virus and the normal virus. The ART, when you are giving ART, they will kill the normal virus, which are not mutant, or naive virus, you rather say. And what will happen? The mutant virus, they go on multiplying. So there will be a time when only the mutant virus will dominate, and the other wild viruses are not there. The longer duration of therapy, prodigious HIV replication rate and error-prone reverse transcriptase, varying degree of drug resistance bound to occur even with the high treatment adherence levels. So if it's long treatment, and though the adherence good, then also there may be chances of development of resistance. ARV suppresses viral replication and thus prevent mutant forms from the development. So that's why we take the multiple drugs, not a single drug, triple drug. We know from the very beginning, we know triple drug therapy, the FDC. So triple drug combinations we prescribe because it will suppress the viral replications and prevent the mutant form. But if you take the only one or dual drug, the chances of resistance quite high. If antiretrovirals are not taken, or dose correct, either not taken, or if the dose is improper, or absorption is improper, if there are drug interaction, or sometimes there is vomited out and all. If there's the compliance is poor in any way, the drug level which should be maintained to suppress the virus, this is not maintained due to any reason, that will lead to resistance. Incomplete suppression lead to more replication, more opportunity for mutation to arise, and more chances that resistant virus will emerge and treatment failure occurs. So after giving ART, how will you, now we have learned when you call this a failure, treatment failure, whether viral, immunological and clinical, then what is the usual mechanism of failure, then how to predict or how to monitor whether this baby is going towards a failure. So very important, the follow-up and monitoring, and that should be very crucial. So monthly monitoring, we'll see the growth. As I said, there may be growth failure, but before telling it's a growth failure, must look for the dietary deficiencies there or not, and diet has been given or not. Then there may be developmental delay, or sometimes there may be development achieved which is regressing back if the children are younger enough. So regression of milestone. What do you mean by regression? It means whatever the milestone they have achieved, they're losing back. The baby who could walk, now he can't walk, he can sit only. So that is called regression milestone. Then, of course, the nutritional, each and every visit we should look for the nutrition, how much he's taking, is there any deficit in the nutrition or not. Every visit, presence of any new clinical event. This is very important. Sometimes they don't complain even until unless this is disturbing their day-to-day life or it is painful. It's a common tendency of a human being. Until analysis is painful, no one is bothers. So it's our duty as a healthcare provider. We always look from head to toe, thorough examination, systematic examination must be done in each and every visit per child. So, and do the clinical staging. Then, of course, in every visit we do the TB screening, 4X screening. What are the 4X screening? Baby is not gaining weight or loss of weight from the last 3 months, more than 10% loss of the last 3 months, which is the maximum recorded weight in the last 3 months. Then we say that there's a loss of weight. Then there will be history of contact and fever and cough. So you always look for the fever and cough. Again, and all fever and cough is not TB. So we have to judge the medical officer on the artist, and they will judge whether this fever is because of some viral fever. Because if any adult person have a viral fever, they can contact it and can have viral fever. So always rule out that. Even in the amoebiasis, diarrhea can have a fever. So fever does not mean as a tuberculosis. Of course, you have to apply your clinical acumen. Then you have to go for the screening. Then evaluate the treatment adherence. It's this is the issue in, I would rather say, this is the issue in pediatric age group. The treatment adherence is very important. And you have to use many tactics to get the history of adherence failure. Well, I'll be talking on adherence. I'll discuss a few of that. Look for the symptoms of iris. It's very important. Sometimes we might confuse with the failure, like iris, immune reconstitution, inflammatory syndrome. What will happen in iris? Suppose a baby, you're treating with a tuberculosis patient, and it is more common in a tuberculosis. If you treat with a tuberculosis patient and giving ART and ATT, suddenly this baby develop convulsion. Because of the convulsion, or there's some respiratory distress, you might think there's a deterioration of the disease, and we have wrongly diagnosed tuberculosis, and there may be a progression of the disease, there may be a treatment failure. But no, it is a immune reaction towards the immune reconstitution. As soon as we are giving ART therapy, so what will happen whenever you're giving ART, there's a suppression of the viral load. So CD4 will be high. CD4 will high. That means immunity will be high. That is the immune reconstitution, and that will protest against the virus, and that is called inflammatory syndrome. So it's not that there's a failure, rather there's a improvement. And always look for the CD4 count before telling the iris or not, because in CD4 count will be high in iris because it is improving, the sign of improvement, but it may hamper the day-to-day, or may have a painful lesion, may have a conversion, enlargement of lymph node, or respiratory distress or pneumonia. So adverse reaction to ART and opportunistic drugs. Suppose we have given some drug and it is causing pruritic eruptions. We might think it's a stage 2 because of the pruritic papillary eruptions, and it is because of the drug. So always look for the drug if they're causing this. Then some adverse reaction, antiretroviral drugs can have some adverse reaction like hepatitis, CNS convulsion, and we might think it is because the disease is still, and in spite of giving ART, baby is deteriorating. So what will be the common interpretation? It is failure. No. So you have to be very judgmental while telling us failure, whether it is adverse reaction to drug or treatment failure. Then of course, drug interactions. Some drug may interact with the other drug. So they may decrease the MIC blood levels, and so the blood level will be decreased, so it is not sufficient to suppress the viral load. That can happen. Suppose like we know there are some drugs like enzyme inducers, very commonly you talk is in a discussion in ART, that's a rifampicin. But other than rifampicin, like phenytoin, phenova is very commonly used in convulsion in children. Febrile convulsions are very common in children. So if there's a febrile convulsion because of the fever, baby develop convulsion, you are given the phenobarb, and that is enzyme inducer, and that can increase the metabolism of other drug. So the drug level will be decreased, and that may be a deterioration. So always look for the drug to drug interactions. Check doses of the ARB as per body weight, because the younger the age, rapid is the gaining weight. So we say when a patient, baby comes in the newborn period, in the first day we say in hours. In first hour we say in minutes. How many minutes of the baby's age? So in first hour we say in hours. Then in the first day we say in hours. Then we say in days. Then we say in weeks. Then we say in months. then we say yes. So depending upon how young the baby is, and the gain in weight is also in the similar way. In first few days, we'll say in how many gain in weight in the daily basis, then weekly basis, then monthly basis, then we say, and the height is 3 months or 6 months basis, and weight is a monthly basis. So it's very important. Always keep an eye on the weight of the child, because it may change because of the good nutrition, because of the therapy, because of the well-being, mental well-being, everything that will change, and the baby might gain weight. So if you won't look for the weight in every visit, you might miss the ARB, because ARB will be always we do at the per kg body weight. So it will be less than the required drug for that particular child if the weight is already increased. So it is you have to modify the drug in each visit depending upon the increase the weight. So it's very important. Now we'll do the clinical, as we are giving the ERT treatment, the first line ERT, the clinical T staging is very important. So what we'll do, if the new or recurrent event on ART or management options. So no new event in the stage when baby came to the OPD and you see there's no new events. So we'll say T1, stage T1, because on treatment, we'll do the same treatment, maintain regular follow-up, viral load monitoring. And this is very important. One of the important issues, always appreciate the child. Oh, you're so good. You don't have any problem. That means you are taking the drug very good. So that will boost up their morality and they'll have a good compliance. So always appreciate the child and the caregiver if there is no new events. And of course, always in every visit, though they are taking the good nutrition, always say something about the nutrition so that they can maintain the good nutrition. Then stage 2 events, treat and manage the clinical event. If there's any stage 2, recurrent respiratory, upper respiratory tract infection, skin infection, superficial infections, these are all in stage 2 events. So treat and manage the clinical events, continue the same ART regime, assess the adherence. Each and every visit, you must assess the adherence, nutrition, and weight, and appreciate accordingly. Offer ongoing support to improve the adherence. Schedule an earlier visit for clinical review or timely viral load testing, depending upon the criteria. Then stage 3 and 4, treat and manage the clinical events and monitor the response. Check whether patient has received 6 months ART or not. After taking the 6 months, we usually assume that after the consumption of the ART for 6 months with the proper compliance, there will be viral suppression. So there should not be any stage 3 or 4 disease. But even after that, if there's stage 3 or 4 disease, then you may suspect whether baby is going towards a failure or not. So assess the adherence, very important. Again, nutritional status. Offer ongoing support to improve the adherence. You might give some clues, some ideas to increase the adherence. Advise more frequent follow-up. Timely CD4 and viral load testing. Refer to SASAFE if diagnosed as a treatment failure as per viral load algorithm. I'll be talking on that. So adherence monitoring after initiation of ART is very important. Why? Because pediatric ARV options are limited. We don't have too much drug as if we compare with the adult one. So hence ongoing adherence monitoring is very essential for children to remain on the first line regime as far as possible. So very beginning you have to counsel the parents. देखिए मेरे हाथ में ज्यादा दवा नहीं है. आप यदि ये दवा ठीक से नहीं खाएंगे तो दवा फिर बाद में काम करना बंद कर देगा. तब हम लोग को बहुत ही तकलीफ होगी क्योंकि ज्यादा दवा तो बच्चों का है नहीं, तो फिर प्रॉब्लम में पड़ जाएंगे, हम लोग भी पड़ जाएंगे, आप भी पड़ जाइएगा. तो यू हैव टू काउंसिल इन दैट वे कि दैट द adherence must be very good. Poor again, you have to counsel the child also. If it's an adolescent, then you have to counsel on the adolescent way. Poor adherence plays a significant role in the emergence of drug resistance and subsequent treatment failure. This is the main cause of treatment failure, whatever we are seeing in the SASAFE or in pCoEs, only because of the poor adherence. Checking for treatment adherence along with the clinical monitoring and T staging at every visit must be ensured, and it is always to be done. Ongoing adherence monitoring and support to ensure treatment adherence to be more than 95%. Barriers to adherence should be assessed and addressed regularly. And this adherence issue, every contact, either in the counselor's contact or in the nursing staff's contact with the patient, or in the doctors when the patient comes with the doctors in contact, everyone should have a responsibility to look for the adherence of the drug. And you should be proactive. Because I'll give you one example, like what we say, oh, you are, whenever taking medicine morning, at what time? Oh, you're taking medicine at 6 a.m. or 7 a.m. Okay. What will do when the school will open? What is the school time? They'll say school time is 7. So how will you take the medicine? I'll take early in the morning. Will you remember? कभी कभी तो ऐसा हो सकता है ना, आप देर से उठेंगे, स्कूल की हड़बड़ी रहेगी, फिर आप कैसे खाएंगे? So these issues you have to discuss, how to manage the timing, how to manage the adherence. Sometimes we have seen many cases, baby mother said, okay, I am giving the low, especially in low periods, they said, हाँ दे रहे, regularly I am giving, and it's 100% adherence, or not, we don't miss it. Then I called the girl was in a 6 to 7 years old girl child. I called her and said, okay, आप निकल जाती हो, जब मम्मा देती है आप खा लेती हो. After giving many things and coercing and many bribing and many things, then she said, मुझे अच्छा नहीं लगता है. She used to spit it out. As soon as mother turns the face, she used to spit it out. So in this way, you have to think. Sometimes again another patient came with us, came to me and complained ki 100% hai, even after that there's a biological failure. And that particular patient, we got the history that after every dose of lopinavir syrup, baby is to vomit, because she does not like that smell or whatever the taste, whatever it is, she is to vomit. So what is the importance? It's not going in the abdomen, it's not absorbed. So always ask कि आपका दवा खाने के 15 से 20 मिनट के बीच आपको उल्टी तो नहीं हो गई ना? Or sometimes there are hurried peristalsis, baby is suffering from diarrhea, severe acute severe diarrhea, and she took the medicine and is washed out because they hurried peristalsis. So all those things keep in mind while taking the adherence monitor. It's very important, because the mother will complain, mother will say they are giving 100% pills daily. हम तो देते हैं. Someday they might hide the tablets. The child will hide the tablet so that mother will think. Even sometimes we have got mother बोलते हैं कि मैं हाथ में दे के जाती हूँ, मैं काम में निकलती हूँ सुबह. She's done some helping hands for some other families. She said कि मैं तो दे के जाती हूँ, रोज खाती है, रोज दे के जाती हूँ. But this is not the ultimate. We have to see, have to watch whether the baby has swallowed the tablet or syrup or pellet, whatever is given, and there is no vomiting following the drug. At least 15 to 20 minutes, because it will take at least 30 minutes to be absorbed. So it's very important to see the adherence while dealing with the failure child. Because what we get in our SASIP or in pCoEs, maximum because the poor adherence. And sometimes they say they are very clever. Sometimes they say कि हाँ पहले हो जाता था. I don't want to take the medicine and all. But now after coming to this, अभी last महीने से मैं ले रहा हूँ. So again you have to think, because last medicine is only one month, so you have to see consequently for first, second, and third month also. So this type of things, and sometimes they become LFU, again they come, and all. Maximum case, if you go through analyze the cases of failure, you will see either the miss or LFU, or they are denying something, they're hiding something, and this maximum they are having poor adherence. And after that, because of the poor adherence, already resistance are developed. So after that, they are good adherent, even they are failing. So adherence is very much important for preventing the failure. So considering the treatment failure, before diagnosing treatment failure, child should have received the current ART reading for at least 6 months. Adherence is at least more than 95%, equal to more than 95% each month, each consecutive last 3 months. Then there should not be an acute and opportunistic infections, immune reconstitution syndrome, whatever I've discussed, and just summarizing, it should be excluded. Malnutrition may make clinical failure, whether should be addressed, whether given a nutritional therapy. Adverse drug reaction may mimic, as I said, and there's a drug-drug interactions. So I'm not going in detail. This is the chart everyone is following in ERT center. When to do the every month we'll do the clinical examinations and thorough clinical tests, and we'll do the CD4 6-month interval, and then the plasma viral load at the 6 months, then 12 months. If it's okay, virally suppressed, then go for the yearly. So these are the guidelines we'll do. Then so there's a viral load algorithm. If the patient comes with the viral load, we'll see whether the criteria, as I've already discussed, what are the criteria to be fulfilled. Then you see the viral load, consider the viral load. So if his baby has already taken 6 months and the adherence is good, then you see the label a viral load. Oh, okay, it's the less than 1,000 copies per ml. According to NAC guideline, that is the virally suppressed. So continue the same treatment, appreciate the child, give boosting effect, give nutritional advice, age appropriate immunization advice, and again boost up the adherence. Then if it is a more than 1,000 copies, then what will do? Then you see whether this is the first time they have come, or is there is a step up adherence is done for consecutive 3 months. It's not done, do it. Adherence must be more than 95%, and you have to give the step up counseling. Again, there are a few steps. Few steps are there in the guideline also, how to step up the counseling, how to boost up your counseling, how to make them adherent. You have to give very many options. It should be, I mean, adjusted according to their needs, their activities, their schooling. Now school will open, so we have to think of that. School activities, school outside school, the games, tuition, dancing class, playground, whatever they do, it should be adjusted accordingly. You have to take in confidence with the caregivers. They have to decide how to take the medicine in time with the involvement with the multidisciplinaries. So because the children are growing phase, they have lots of activities. So we have to consider how to take the medicine in proper way. We should not forget while dealing with the HIV child, or not only we should not think about the HIV only, we have to think of the child also. So it's very important to increase the adherence for 3 consecutive months, then ask them to come and again do the viral load. If the repeat viral load is more than less than 1,000 copies, then that means then again boost. Appreciate, oh, well done, you have done a marvelous job. So we always boost up both the child and the caregiver and ask them to continue the same treatment. If there's a failure, then refer to the SASEP or pediatrician, pediatric experts, or the pCoEs. So target, maybe target, how you see, if it's less than 1,000, target maybe not detected, means that the level of HIV is too low to be detected by the measured by the test, whatever test we are doing. Does not mean the HIV has disappeared. This is very important. When you'll see, they will see the report, oh, it is target not detected, ye to hai nahi, virus to hai nahi, khatam ho gaya. There's no need to go to ERT center. They might be missed and lay few. So no. Counsel them does not mean that HIV has disappeared. HIV is still present in the reservoirs, but it's not picked up. The machine is not picking up the virus. It's so low. Continue current regime. If 1,000 under the current national guideline is considered suppressed viral load, continue the same ART regime. Next viral load testing to be done as per the guideline. Now it's more than 1,000. Then 3, as I already said, 3 sessions, step up adherence, enhanced adherence counseling, repeat viral load to be done, and you see whether more than 1,000 or less than 1,000. How to do the step up adherence counsel? It's very important. A minimum 3 sessions are required for a step up adherence. Additional sessions if needed to ensure that adherence is more than 95%, 3 consecutive months. All counseling sessions are to be taken preferably with the same counselor. So there will be rapport. So it's very important for the counselors with the children to make a rapport building. So first you have to make a rapport with the child. It should be comfortable, positive counseling, friendly attitude and all. And same counselor will counselor all 3 counseling, so that it will be, baby will be confided in the counselors. So both caregiver and the child should be counseled. Even sometimes you may need a second caregiver to be counseled. And in many situations, we have seen the mother is working outside and the child is taken care by their elder sisters. Sometimes you have to ask. Sometimes this happens in our center also. We have noticed baby, mother and baby came to the ERT center. We counsel the mother and the baby. But mother said, "मैं तो दवा नहीं खिलाती, मेरा बड़ी बेटी उसको खिलाती है." So whatever we counsel the mother will tell to the elder daughter, and then whatever she will conceive, she will understand. Then she will give it to the baby. That is again, it is error prone. As I said, the reverse transcript is error prone. This method of counsel is also error prone. So because whatever you said may not conceive everything by the mother, and whatever mother understood from their knowledge, she will percolate to the elder daughter. So always ask who will directly involve with the taking the pills and giving the pills to the child. You call the, so you can call the elder daughter and counsel her separately. So it's very important who is directly taking care of the child. You have to counsel directly to those caregivers. This session can be conducted when the caregiver brings the child to ERT center to collect medications for the child. Counselor needs to review all the factors that led to non-adherence, provide customized counseling with an individualized adherence plan. As I've already said, it may be different for different child, different issues might be there. Yeah, it should be customized. And It should be individualized. You cannot apply the same method in each and every child. It should be according to their need, their activities, and their provisions. Check the child's treatment adherence to create baseline. Caregiver, do the caregivers understand the viral separations? Assess the possible barriers to the adherence. What could be the problem? As I've said, what, when, how, and who. What do you know? When you will give the days? Who will take? How will give the medicine? All those questions to be taken. Okay. So I think I'll finish my talk. Then I'll take the questions. I think. Disclose the status. So reminder being used or not. Disclose the status to the child. Baby, but does baby know that he's having HIV or not, so that it will help in the adherence or not? So these issues to be taken care of while dealing with the counseling. Develop an adherence plan with the address that identified the issues. And in case of children, explain the reason for taking medicine. They might ask, मेरा दोस्त तो दवा नहीं खाता, मेरी बड़ी दीदी नहीं खाते, मैं खाती हूँ, क्यों खाते हैं? So you have to explain, because until you won't explain, they are not compliance won't be good. So you have to explain according to the maturity level, according to their knowledge and IQ, how much they can understand about the disease. So you have to explain the reason for taking medicine. It's effective, age appropriate words. Build a rapport with the, already I have said very beginning, you must make a rapport with the child, others it's totally futile. Motivate the to take the medicines regularly and use reminders. You can give example, but you are having HIV, so you are taking medicine. I am having hypertension, so I am taking medicine. Maybe रोज सुबह दवा खाती हूँ. What is our aim? Our aim is to be healthy. हमको बचना है, स्वस्थ होकर बचना है, हेल्दी लिविंग होना चाहिए. वो मेडिसिन के बिना, वो मेडिसिन की वजह से. I can give last time I gave an example of one child. Let's see. You can see without specs, but I can't see without specs. हमको मतलब है देखने. So if I can see the things clearly with the specs, why don't you use the spec? So I'm using specs because I'm having the problem in my. Similarly, you are having HIV virus, you have to take the medicine to be healthy. So हमको healthy रहना है, whether with medicine or without medicine. If you are healthy with medicine, there's no harm. Why don't you take the medicine? So you have to explain in their language, their way, their understandings. As is the mental health of both child and caregivers. It's very important whether they're mentally depressed or having any issues, because we know it is HIV itself has a very immense mental tension and psychological pressure. Then, of course, the last 2 years, we are seeing the unprecedented pandemic of COVID-19 that has exaggerated the mental health problems in the all the public, more so in the disease persons, so even in the HIV also. So that is that issues to be taken care of. And if there's a depression, because of the depression, they won't take the medicine, mother won't feed the child in the medicine. So you have to always take care of the mental health issues. So first counseling, you call the baby after 15 days as deemed fit by the counselor. And all, of course, while counseling, you should look for the timing also when you call them, whether you don't hamper their day-to-day activities or schooling or tuition or whatever they're doing. So in that way, it will be customized. Review child's adherence between the first and second sessions. Care maybe should be discussed by any new issues or any gap in adherence. Motivate for disclosure of the status to child, if not already done. Modify the adherence plan to tackle the identified issues. So you have to empower the caregiver how to increase the adherence, how to disclose the status of the child. Sometimes they say, मुझे नहीं बोलना है, मैं आपके सामने बोलूंगी, आप बोल दो. So you always empower them how to disclose to the child, and modify the adherence plan if there is any issues. And again, in child, you call the child and always praise, ba, aap to bahut achhe ho, healthy ho, ba, because you are taking medicine, you're so good, you're so sincere, you're so looking so good, and all those you have to praise and reward the child if there is more than 95%. Assess the child's understanding of importance of ERT. Motivate to take medicine regularly and use reminders. How to usually we ask कि आप कैसे याद रखते हो, सुबह रोज मेडिसिन लेना है, आपको कुछ याद ऐसे याद आ जाता है, सुबह सुबह कभी भूलते नहीं हो? तो they can give the clues कि आप कैलेंडर में दागी रखो, या अलार्म लगा के रखो, मैसेज बना के रखो, कुछ भी you can do. And also everyone is having mobile and all, they can can give you a reminder. So you have to take give the ideas to them, and you can take their ideas also. Then a step up again, then if adherence more than 95% in the last 3 months, Plan a repeat viral load. Explain caregiver to keep the viral load appointment and all. Praise the child and motivate for the good adherence to maintain. And this is not adequate, then it's a serious issue. Discuss the risk of treatment failure due to non-adherent. What will happen if you are not adherent? Assess 5A treatment adherence. That is, modify the adherence plan to tackle. Sorry for the interruption, just a minute. Okay, sorry for the interruption. Okay, so if the adherence is not adequate, plan for the further session. You can give an extra session for the improvement of the adherence. Discuss the risk of treatment failure due to non-adherence. What will happen if you are not going to have a good adherence? You ask about the 5 A's. Then I talk about the modify the adherent plan to tackle the identified issues. Motivate for the disclosure of the status of the child if not already done. It might help in improving the adherence if he knows that he is having some disease for which he has to take the medicine. So motivate to take medicine regularly and use the reminders. Now, again, I have already discussed if there's a more less than or equal to, then appreciate both caregivers and continue the same treatment. If more than 1,000 copies, you can give it to the refer to the SASIP, and the caregiver is unable to take the child physically, then you can have a Zoom and SASIP referral, and that will be explained by their treating physician. The medical officer is there in the ART center. They will help them to go to the SASIP either physically or digitally. So suspected treatment failure, growth failure, delayed developmental milestones, as I've already discussed all those things, new wise, and this is again repeat slides because more than 6 months, 95, this I'm repeating. Sometimes we do get patients from different centers and refer to us without going through this 3 months step up adherence and doing the viral load, and after 3 months, and it is before that they refer. So always look for these points before referring to the patient and labeling as a treatment failure. What is the cause? I've already discussed, because it's maybe non-adherent, maybe resistance, maybe why there's a non-resistance. Developmental resistance is maybe de novo or maybe due to induced. What is the causes of induction? Non-adherence, poor adherence, inadequate drug levels. Means either non-adherence or inadequate drug levels, ultimately the same, means blood level is not maintained to suppress the viral load. That may be due to non-taking, it may be incorrect dosing, it may be poor absorption of the drug, it may be drug interactions, or there may be some defect in the genetic difference, and there is a decrease, there's a difference in the metabolism in each and every individual. And of course, as I said, there may be drug resistance in de novo. So switch it. Now, because there's a failure, we have to change the drug. The certain conditions, many patients are expected to have a significant NRT resistance at the time of switching. So what are the things to be considered while switching the drug? One has to consider nucleoside class cross resistance and drug infection. Like cross resistance exists between the stabudin and derivatin. Though stabudin is no more in the our program. In it, like such as ifaprin and nevirapine, usually there is a complete cross resistance. High level of zidovudine and lamivudine resistance reduces the susceptibility to HIV to avacavir also. So if you the scope of there is there, if there's can do the resistance pattern testing and all, that will be easy. Before in the Western countries, they follow the resistance pattern, they see the drug resistance, then they give the alternative drug, a second line drug or third line drug. Tenofovir avacavir may facilitate evolution of K60 drug resistance mutation, which mediates resistance to the NRT other than zidovudine. So steps to be followed for review. Step 1, define the treatment failure. First, you have to look whether really baby is having failure or not, as I've discussed till now. Then step 2, SASIP decide to new NRT component of the second line. So first we'll see whether really treatment failure is there or not, or the following all the criteria to be fulfilled. Then what to do? If zidovudine used first line, NRT choice in the second line will be avacavir. Depending on the age, of course, and weight. Tenofovir, if more than 10 years, more than 30 kg. If avacavir and tenofovir used, then first line NRT choice could be zidovudine on the hemoglobin of the child, depending on the hemoglobin is more than 9 or less than 9. I'll show in the subsequent slide. Continuing the lamivudine, the backbone reduces the viral fitness. It will be there in all the combinations. Then step 3, decide on the third component of the second line regime. So the first is there, second is lamivudine, what will be third? Third, if NNRTI, that is nevarapine, efavirenz is used, then first line, then second line will be lopinavir, ritonavir. With choice in the second line because atazanavir, ritonavir, the older children we don't use in pediatrics. If PI used, then first line, then the NNRTI will be the second line and based on the age. And we'll see now the dolutegravir has been introduced. So how it will be changed from the dolutegravir, if it's there in the first line, what will be in the second line? If it's the dolutegravir based first line, what will be in the second line? Patients and then step 4, patients and caregivers agreement on the treatment follow-up monitoring plan is very important aspect of treatment of first line failure. If the cause of poor adherence is persist, compliance is not good, understanding about the failure and the treatment and the drug is not clear in the caregivers, there's no point in giving in treatment. Because again, they'll come with the poor adherence and there'll be resistance and all. So it's very important to counsel the parents and caregivers after the first line failure. Counseling for adherence, linkage to the specialist care depending on the drugs and procurement of the drug or any special advice, follow up a monitoring plan. So and there are different situation might be there. Second line ART failure less than 3 years. Now we don't divide. I'm skipping this slide because we don't divide now 3 years, less than 3 years or more than 3 years. We now divide in the 6 years. WHO recommended dolutegravir as the preferred first line drug for all children in the age of more than 6 years and more than 20 kg. So see the weight less than 20 kg or is and age is below 6 years. Then the recommended regime will be abacavir, lamivudine, and lopinavir, ritonavir. This is the first line regime nowadays in our program. If it's between 20 to 30 kg, that means dolutegravir can be given because dolutegravir is indicated about 20 kg and above 6 years. So here you can, instead of lopinavir, ritonavir, you can add abacavir, lamivudine, and dolutegravir. But if it's more than 30 years, 30 kg and above 10 years, then tenofovir is indicated. So in spite of abacavir and lamivudine, you can give tenofovir, lamivudine, and dolutegravir. So it is a viral failure. So treat and stabilize the acute condition, opportunistic infection, baseline test CD4 testing, other lab investigation. I'll see. And baby is positive. We did all those investigation. Now decide the age of the child. If it's less than 6 to 10, more than 10. The same thing as in the flow chart. If less than 6 years and less than 20 kg, first line of treatment will be abacavir, lamivudine, lopinavir. Between 16 to 10 years and weight 20 to 30 kg, any or this abacavir, lamivudine, and dolutegravir, ALD. It's more than 10 years and the body is more than 30 kg, no renal disease. Then only if there's no renal disease and more than 30, then only you can give the TLD. But if renal disease is there, then again it will be a different treatment. And it's less than 30 kg, then also you cannot give TLD, it will be ALD. So even in a DTG based regime, if it is along with the anti-tubercular drug treatment, ATT, and if you're giving, of course, the rifampicin, the one of the drug in treatment. So when you're giving the rifampicin based ATT, all the guidelines until it's a multi-drug resistant DTG, along with the DTG, what will be the combination? The child with rifampicin ATT should receive an additional dose of dolutegravir every day after 12 hours of the first dose. So first line pediatric regime and the HIV/TB co-infection. So less than 20 kg, so it will be ALD. Abacavir, lamivudine, lopinavir, ritonavir. But you are adding rifampicin ATT. So what will happen? Rifampicin is an enzyme inducer that will give the decrease the level of ritonavir. So you have to do the super boosting of ritonavir. And super boosting means normally it is the 4:1 ratio. Here it will be 1:1 ratio in the lopinavir, ritonavir. So you have to add separately a ritonavir tablet, which is though difficult to procure and available formulation in pediatric age group. But if you consider to give the lopinavir, ritonavir along with the anti-tubercular drugs with rifampicin, then it should be super boosting. Now it is 20 to 30 kg. and 6 to 10 years. So dolutegravir now can be given. So it is a abacavir, lamivudine, dolutegravir with additional dose of dolutegravir after 12 hours. It's very important to note. Whenever you take the dolutegravir, note the hours and after 12 hours. So we don't write BD dose and twice a day dose, and it should be after 12 hours. Then if you above 30 kg, then again same TLD, tenofovir, lamivudine and dolutegravir with additional dose of dolutegravir after 12 hours. Now, second line regime. This is a very big issue. So we will try to preserve the first line drug for children. Then if it, we'll give our all efforts to maintain in the first line. But if there's a failure in the first line, then we give the second line. The second line regime, thereafter is very difficult to have a second line failure treatment. So if this a patient is on JDN and LPBR is less than 20 kg and 6 years, what will happen? No change in the regime. If child has advanced disease, like we know the severe malnutrition, stage 4 disease, rapid below 5 years, we consider as an advanced disease. After consultation of pediatric center of excellence or pediatric experts, you can shift it to abacavir, lamivudine, nevirapine or ALE, depending on the availability of ephedrines. There are not. And improve the adherence, give the nutritional diet, wait for the weight to be more than 6 years. And if the weight is more than 20 kg, then you can convert it to ALD. But if the child is more than 10 years and 30, then general LPBR child will be changed to tenofovir, lamivudine and dolutegravir. But if the baby is getting AL LPBR, then again, there's no change in regime can be done. If child is advanced disease, then again, you have to consult the pCoE and you have to refer the patient, and JDLN or JDLB can be given. But there's an issue. As we are using the zidovudine, we have to look for the hemoglobin. If hemoglobin is more than 9, then it's okay. You can use zidovudine based lamivudine and nevirapine in a day, but it's less than 9 gram %. Again, it's very tricky issue because we have seen many cases. It's not drug induced. You can continue. It is hemoglobin less than 9 gram because of lack of iron-rich diet or something else, because of the hookworm infestation or some other causes there for anemia. So you treat the anemia, cause of the anemia, increase the hemoglobin level, and as soon as the hemoglobin level is built up, you can shift to the previous regime, that is JDLN or JDLE. And if it's more than 6 years, then there's no issue. You can go convert to zidovudine, lamivudine, and dolutegravir if hemoglobin is more than 9. Again, if it's hemoglobin less than 9, then again you have to think what drug will give, because this is a big issue for us, for pediatricians dealing with the children who are already exposed to tenofovir, abacavir, and having anemia. Then continue same treatment and till the hemoglobin is go up, then you have to give JDLD. But what happens if there is again develops anemia after zidovudine? Then there is a real issue to think of. So what will do? If JDLE, already on JDLE, then you go for the abacavir, lamivudine and lopinavir. So we converted the PI based that. Till pediatric DTG is available. Yet we are demanding the DTG formulation for pediatric child 5 milligram and 10 milligram. So when until it is available, we have to continue same this regime. As soon as there will be more than 20 kg and 6 years, we convert to ALD. If it's more than 10 years and 30 kg, we'll then give to TLD. And if it's an abacavir based regime, then you can give the JDL LPBR if hemoglobin is more than 9. But if it's less than 9, then continue the same AL LPBR, AL till the hemoglobin is up. So continue same regime till the anemia is corrected. See the cause of anemia, treat the anemia, and then you can convert to the JDL LPBR. When you persist, then you have to take the expert opinion, means you have to do the permutation and combinations and hue and cry for the management of this type of patients. And if it's more than 6 years, more than 20 kg, then no problem. ALE can be converted to ZLD more than 9. But if the baby's hemoglobin is low, then you can give the DTG and lopinavir, ritonavir. As DTG can be given more than 6 years, but sometimes what will happen if the lopinavir is not already exposed, then we can't give the lopinavir. Then you have to, sometimes you can think of the darunavir or ritonavir. And again, ALD, if it's ALD, you can, in as all age, we can convert to ZLLPBR. If it on TLD, you can convert to the ZLLPBR. So initial sickle 9 ART and ATD in children with co-infection, the same, there's nothing different. We know if we were giving the lopinavir ritonavir based treatment, then you have to super boosting the ritonavir with the ratio to 1:1. And if you are giving the dolutegravir based treatment, we have to give another drug of dolutegravir after 12 hours. And that is what it is written in this flow chart. Already ATT, no treatment failure, identified control, reformation containing drug, ATT, sickle 9 ART preparedness counseling, and initiate sickle 9 ART containing lopinavir super boosted. Need to initiate sickle 9 ART with concurrent detection TB, treatment preparedness counseling, initiate reformation containing ATT TB first line. As soon as they are stable, now latest guideline, don't have to wait for 2 weeks to 2 months. As soon as they're okay, you can start ART. Initial sickle 9 ART containing lopinavir super boosted ritonavir. Patient stable after 2 weeks of the TB treatment. And if the patient is already on sickle 9 treatment and detect HIV TB co-infection, treatment preparedness, initiate reformation containing ATTB regime on priority. Modify the sickle 9 by the replacing lopinavir with the super boosting. Whatever the drug, if it's dolutegravir, then you have to give a second dose of dolutegravir after 12 hours. Again, it is very important and very crucial to monitor this type of children. Body weight, again, every visit you have to see the body weight. In the clinical monitoring is very important issue, because in a hurry, there's a lot of rush in the medical OPDs, and then they may be ignored, but they should not ignore this type of problems. Opportunistic infections, forest screening in every visit, growth and development assessment, and T staging, very important. And for the medical officers who are working in the ART center, is very important to see the growth and development, and it is very difficult for them to see the growth and development. But I would rather say that's not at all difficult. You have a immunization card, you have a white card, and there is a graph. Just put on the graph. You ask someone, take the weight and put on the graph. You will see whether going up, static, or going down. From the mother only say if the baby is having growth failure, because that graph can be appreciated by anyone, any layman person. And development also, there is a chart. You just put on a one bar, vertically draw, according to age, you draw a vertical line. See how much is crossed. So all those milestones which are on the left side of the bar should have been achieved. So this is very easy. They don't have to remember everything, and you can see the graph. And then T staging to be done. Of course, in every visit, treatment adherence. If adherence is poor or any major wise identified, steps need to be taken to improve the adherence and T2Y. Lab evaluation based on the type of test being done or symptoms detected. So depending on the clinical features, presentation, you have to do the lab evaluation. And of course, CD4 count, we know every 6 months, and viral load every 6 months. So it's very important. Poor adherence to ART often results in development and resistance to ARV drugs, and is the most important cause of treatment failure in children. But that is what I have said in the very beginning. Hence, intensive adherence monitoring of a child on sickle 9 ART regime is very, very important. Infants and children are dependent on adults for timely and correct doses of ART. So it is very important to know the occupation of the caregivers. Child must directly observe to swallow the medicine, as I've already said. Poor adherence can also be due to the caregiver's issue discussed previously. Hence, the caregiver must be assessed for issues and counseled accordingly, and whether they are mentally sound or not, whether they have a time or not, whether they are having what type of occupation, all those things, so that we have to give more attention to the caregivers than to the child for the adherence issues. Use all adherence tools to support the child and caregiver. Flip charts, coloring ART calendars, peel box, favorite TV series. Disclosure to child is appropriate. So the disclosure according to the maturity and understanding level of the child, you have to do. Criteria for diagnostic in line failure is the same as those for the diagnosis of first line failure. We'll do the viral load, and we'll see the less than 1,000 or more than 1,000, considering they have taken the drug properly, adherence is good for at least 6 months and all. So a case of children on the diagnostic in line failure with no new ARV drug options, we don't have many drugs. A summary should be sent to NASEF for opinion on salvage remission and drug sensitivity testing. Continue the same sickle 9 regime till the decision is taken by NASEF. Close monitoring on doses of ARV and others in these children, very important. Pediatric formulations. We have asked for the pediatric formulations of ARV used as third line regime in adult are currently not available, like raltegravir, darunavir. We have asked for the dolutegravir also, also for pediatric formulations. Demand of third line regime will increase, and as access to viral load testing improves. So what is the key point of my presentation is early and correct identification of treatment failure is vital in the children. Regular viral load testing in children is essential for early identification of treatment failure. Poor adherence plays a significant role in treatment failure in children. Second line ART is being provided for all the eligible children after the approval of SASIP or pCoEs. 100% treatment adherence is a vital issue for the efficacy of the second line. Hence, repeated and continued counseling is necessary for the children and the caregivers. Thank you for your patience hearing. If there's any questions, I'll love to answer. Over to Shweta. May I stop sharing the slide? Yeah, Efavirenz and Nevirapine both are not available. That's the issue, because Zedelin is still there, but Efavirenz is not available. So according to availability and the susceptibility and the according to the regime, we have to make the treatment regime. Okay, if Efavirenz is not available and child is failing Lopinavir, so then you have to add Nevirapine. If it is not available, then you have to add whatever available. If Nevirapine available, you have to do Zedelin. Then yet, so how many additional adherence session? It depends on the compliance and the understanding conditions, maturity level of the child and the caregiver. Sometimes, you know, the caregivers are very adamant, so you need much more sessions. So actually we say 3 sessions. Hello. There's a question: how many additional adherence sessions? Adherence session depend upon the individual. You have to individualize. Sometimes you may need 4, 5 sessions. Sometimes the 3 is enough. So it depends upon how much they have conceived whatever you said, understood whatever you said. Okay.
Ma'am, there's a question in the chat box.
Yeah, I'm looking for that. What is the question?
Yes.
I didn't get it till.
Yeah, it is for children on.
Dr. Nivedita has asked for children on rifampicin and dolutegravir, should we give double dose of DTG plus super boosting with return? Yes. If patient is on rifampicin, whatever the drug baby is getting, either lopinavir, ritonavir based drug, then you have to do the super boosting, and that means super boosting you have to make a 1:1 ratio. Previously it was a 4:1, and now you have to add separate 75% ritonavir extra. That will make it a 1:1 ratio. And if patient is on a DTG based regime, you have to give another dose of DTG 12 hours apart. So we don't say the BD dose on twice a daily, because that will make a false belief he can take after 6 hours, 8 hours, as we do in the other medicines. So it is always to be told, should be taken after 12 hours for the first dose. I think Dr. Nivedita got my point. Then Dr. Desham has asked, ma'am, if the viral load is done in January 2022 and is more than 1,000, adherence more than 95% in the past 6 months. Yes, because the guideline is more, second more than 1,000. So already you have done the more than 1,000, and the 6 months 95% adherence is more than 90. So you can refer it. Yeah. Because if it's more than, and the issue is there's a poor adherence, then only we ask the step up the adherence and do the after 3 months. So if it's more than 95% adherence, you are quite confident, because sometimes we see this type of refer, they have written more than 95% or hardly 80 to 90% adherence. So we have to be very crucial while telling the good adherence, because they might hide. कितना मेडिसिन खाते हो, एक लिए कि 2 लिए, हफ्ते में कितना मिस करते हो, मंथ में कितना मिस करते हो, 1-2 मिस कर जाते हैं, कभी बोलते मन नहीं करता है. लास्ट वीक आई गॉट वन पेशेंट हु सेड मुझे मन नहीं करता खाने का. One patient I got, that was an adult patient, of course she was not a pediatric patient. She said, I don't take medicine because of the bad behavior of that center. So वो center में कोई bad behave किया, तो why you destroying your life? So these are the different issues you have to find out what is the issue of failure, whether it is really good adherence there or not. It's very important. Got my point, Dr. Desham? No, in this case, you don't have to do the repeat VL because you have already written more than 6 months, more than 95% adherence in for past 6 months. If you are confident enough. As more, if there's any issue in the past 6 months, dropped some medicine and missed some medicine because especially January 22 and now it's last 6 months, there's lots of issues of collecting a drug. And sometimes multi-drug dispensing was there. They might have missed, many drugs are there, so they might miss. So this is very important issues to look whether the drug is pill count is not an issue. Pill count we do in the pill in the ERTs and the pill count. Pill count is I think totally false eye washer. Anyone can throw the tablet and say the pill is okay. So we have seen one adult. He used to take regularly the medicine from our center, and he came the failure, first line failure. So then we interviewed, why did you have what was your adherence and how did you take the medicine and all? He said, I'll confess, honestly, I'll confess this time. I used to collect medicine from your center. I used to throw it out because I have to go abroad. And if I take the HIV positivity, then my friends could have known. So I didn't take that certificate, I didn't take the medicine also. I thrown it out. This time I'll be okay. I am sincere, madam, please maaf kar do. So this is the issue. He was an engineer. And he used to take the medicine every month. And adherence was written as I have more than 95% because he is telling that. And he is throwing the medicine. So this is very important issue to know about the adherence. Yes. If a child weight goes down, should he reduce the drug dose? Yes. If it's too much, then you have to identify the cause of the weight loss. Whether it is because all the drugs are given in the per kg body weight. So it is a distribution of the drug in the body tissues and the blood level. So if the decrease, then you have to decrease the weight drug. And you have to look for the why there is a decrease. As I said, the younger the age, more likely to be changed weekly or monthly the weight is. So you have to see why the loss of weight is there. What is the cause? Is it a sudden severe diarrhea or severe pneumonia or any cause of hospitalization or any psychological deprivation and anything? And you have to improve that also. Don't we need to compare 6 months earlier if increase or decrease? In this case, which case, sir? Don't we need to compare the 6 months? Yeah, of course, you have to compare the viral load, whether it is increase, whether it is more than 1,000 in the previous load, or it is decreasing trend. Sometimes we have seen previously it's a 40,000, and after this it became 4,000, 10,000. Though by definition it is failure. But as a drastic change is there in the viral load, we consider to continue the same drug with the boost up adherence, and we have seen the result also. So we have to judge in the individualized basis. Do we need to compare? Yes, you have to compare. Thank you, ma'am. Ma'am, the child is having TB to high viral load. What is the correct time to repeat viral load? With respect to the ATT completion. No, there's no relation with the viral load with antitubercular drug. You give the antitubercular drug, we know that we give the antitubercular drug for 6 months. So whenever the time for viral load, you do the viral load, but you have to give the ATT for 6 months. That's true. But the timing is the ATT introductions won't interfere the timing of viral load estimation. Any other issue?
To unmute the mics if they have any questions. Oh, ma'am, I don't think there are any questions.
Okay. Thank you. Thank you, Dr. Sheta. Thank you all the participants.
Yeah, thank you to all the participants for patient listening. Ma'am, can we conclude the session now?
Yes, thank you. Thank you.
Yeah, thank you, ma'am. Thank you.